Short break, but our video presentations ran on a little bit. Very, very pleased to welcome Dr. Shralka, who is trained in surgery and was a surgeon for 15 years and then moved into psychiatry and psychology. And I read a book of his a few years ago regarding cognitive biases in surgery and was fascinated by it. It's a really interesting field, and he's an expert, and he's rolling out a program I gather potentially around the country in the not too distant future. So we look forward to hearing about cognitive biases in surgery.
Thank you. Thanks, Chris. Thanks for giving me this opportunity to share my views on this subject. I'm especially delighted to be on the same sort of panel with Rona, who has done a pioneering work in this field, not just in this country, but globally. So thank you for giving me this opportunity. As Chris just mentioned, that I was a surgeon for 15 years, and being here brings back those memories, as I used to do everything, whatever you are doing to improve your performance, attending workshop, getting more information. Some things did work, some things didn't. But I wasn't able to understand why some things didn't work. When, because of the accident, I wasn't able to continue my surgical career and I started working in psychiatry, I started realizing why some things didn't work. It was a kind of flash moment for me. And I realized that if, as a surgeon, I would have been aware of some psychological factors, psychological principles, or psychological techniques, I could have been a better surgeon. And with this view, for the last 10, 12 years, I have been sharing this information, this knowledge, this understanding to various surgeons, and surgeons across the specialties have been benefited. This particular topic, I mean, there are various psychological techniques that can be useful to surgeons, but particularly about decision making, it is very, very important, and this is the kind of subtopic that I'm going to share with you. Right. Now, bias is a very generic term, and everybody is aware what bias is. We always have some kind of views or inclination about particular thing. The most common we are aware of are gender bias, ethnicity, race bias. But today, I'm not talking about those general biases. What I'm talking about are the specific bias that affects your decision making. As you all are aware, and I was listening to the previous speakers, and as you know, that decision making is a very important part of surgical performance. And the bias that we are talking about are the specific bias that affect your decision making. Let me start with an anecdotal story. Now, I would recommend this book, How Doctors Think. It is written by Jerome Groopman. He's a physician in US in Harvard University, and he has written a book about how doctors think. Although this book is for lay people, it is very insightful for every clinician as well. In that book, he has depicted his own personal experience about having a surgical treatment. I will tell you the story. What happened is that he started getting a wrist pain after a very minor injury to his wrist. After taking some painkillers for a few days, when it didn't subside, he went to an orthopedic surgeon in Boston. It was the first consultation, had X-ray, which was inconclusive, was asked to have a splint for 4 weeks and come back. Didn't have relief, had MRI, which showed cyst in scaphoid and lunate, but it was told that it is not attributing to his present problems, so again conservative treatment. This went on for a year, and he had all the conservative treatments, and every time he used to ask the orthopedic surgeon, what's wrong with me, what's your diagnosis, and he didn't used to get any specific answer. After a year, when he wasn't improving, he asked the surgeon, what exactly is going on and what are you going to do? He was told, you have hyperactive synovium and you will need stripping of the synovium. Now, he wasn't very convinced with the explanation, so he went for a second opinion. As it happens, the second surgeon dismissed the previous diagnosis. There is nothing like hyperactive synovium. He had another MRI which showed all these three pathologies, and he was told that he would have surgical treatment for each pathology separately with a gap of 6 months, and it would be 2 years that he has to endure all the problems. Okay, wasn't happy with that, so he went to a third surgeon. He was supposed to be the most renowned hand surgeon in the USA, And as it happens with renowned surgeons, within 30 seconds he was told that he would need to undergo arthroscopy. He asked the surgeon why. He said, I will see that later when I go in the theater. He told the surgeon, look, I am a physician. He was the head of the department of Harvard Medical University, and when he persevered with that, the surgeon said, oh, you have got chondrocalcinosis. Now, being a doctor, he did Google and everything, and again he wasn't satisfied with that explanation, so he didn't undergo with the arthroscopy. Now, I'm telling you this in 5 minutes, but this went for 3 years. When he couldn't bear the pain, after 4 years, he went to the 4th surgeon. This was the first surgeon who examined not the pathological, the symptomatic hand, but the asymptomatic hand. And not only he x-rayed in a static position, he x-rayed him in a dynamic position, made the diagnosis, underwent the surgical procedure, and ultimately the outcome was satisfactory. Now, you might say that, come on, it happens. There are clinical opinions, variable. Every surgeon has got various opinions. Sometimes it happens. Sometimes pathological sort of problems cannot be diagnosed in a straight way. At the same time, you need to understand, he was a medical head of the Harvard University, and the consultants he went to were very knowledgeable, very experienced. Still, they didn't get it right. Why? And that's where this biases come. Now, you may be experienced, but if there are certain issues in the thinking process, even with the experience, you may commit some errors, thinking errors, and this is why we need to consider about what this bias. Why should we worry about bias? The first thing is that the research has shown that the surgical errors, not necessarily because of the technical errors, mostly the errors are because of the cognitive errors. And understanding these thinking processes would help to improve the thinking outcome, the decision making, and it is shown to improve the surgical performance. Now, how does it happen? How do we make decisions? How do we make clinical decisions? Now, this is the grid. Now, on the top, it is the process that helps us to make a decision. The first column is perception. We take the information through perceptual apparatus, various sort of, we have visual information, we have auditory information. So, with all these things we perceive, we recognize, we process that, and then we make decision. And these rows are according to the experience, the novices, competent, proficient. So, as we see the process, when you are novice, everything is analytical. You process the information in a very deliberate, analytical manner, and then as you become experienced, it goes automatic. Okay? So, when you become experienced, most of the perception is intuitive. Then it is automatic and everything becomes intuitive. So, from analytical, from everything becoming analytical, deliberate, you become intuitive. But as we heard recently in the previous speeches, sometimes even if you are experienced, some of the situations are like this, that a process may be very complicated, it may be not very commonly done. So, in that case, you resort to some of the part is rule based, some of the analytical, and some of the intuitive. Okay. Now, let us see what is the difference between analytical and intuitive. We need intuitive process because it is subconscious. It spares our cerebral capacity to think consciously, deliberately, allocate our cerebral energy to think about something very useful, very clinically relevant. So, we need to use this intuitive process, and also we need analytical process, and there is a combination. And the problem happens when there is a mismatch, and especially with this intuitive process, some biases creeps up. And unless and until we are aware of those biased thinking, we may commit to those errors. Now, this is the kind of composite. It is a bit complicated, but it is just to tell you how complex is the process about decision making and how we should be taking into account various parts of the decision making process. There are specifically about 35 to 40 biased sort of issues that has been identified in medical decision making. I'm going to share some of them with you just to give a kind of idea how biased thinking is seen in clinical practice. Now, there is something called as availability bias. Availability bias is a tendency to judge likelihood of a disease by the ease with which relevant examples come to mind. We have been told the common things are common, but there is a catch. Now, here is an example. Now, there was a FY1 trainee who was looking after the ward. Now, there was a viral pneumonia epidemic going around, and he came across a 60-year-old woman came to E&E with breathing difficulties. And when he took the history, she told him that because she was under the weather, she took some aspirin tablets for a very bad cold. And he just ran the investigation batteries and got some electrolytes, which did show some acidosis. But as he was aware that there are so many patients with viral pneumonia, she must be having subclinical viral pneumonia. So he had admitted her. When he came back following day, he was told, the consultant saw the patient during the night and he had changed the diagnosis, and according to him, she is suffering from aspirin toxicity. Now, how did it happen? It happened because of this availability bias, because so many patients here admitted with viral pneumonia, he thought that the presentation is also of viral pneumonia. He didn't manage to ask the detail how many aspirin tablets she took. She had taken about 80 aspirin tablets. So, although there were some electrolyte changes, because of his bias that, oh, there are so many patients with viral pneumonia, she must be having viral pneumonia. So, this is a classic example of what we call as availability bias. It was not just the anecdotal clinical example, there have been studies done as well. Now, this mammogram study, it was done in US. What they did, with mammogram, there is a certain percentage of patients which are asked, which are referred for a biopsy. Usually, the rate of the patient referred for biopsy for inconclusive mammogram is about 5%. Maximum, it was supposed to be 10%. But in particular institute, they found that the rate of referral is 15%, 5% higher than average. And when the researcher investigated, they found out that there are particular groups of radiologists who were referring higher number of cases because they had last bad experience. Either there was a medical legal problem or a complaint against the radiologist for missing the diagnosis. So, whenever there used to be a occasion when there was kind of gray area, when they were not sure about making the decision, they used to prefer the patient to refer for a biopsy rather than confirming their diagnosis. So, this was the availability bias. Now, interestingly, this availability bias has been taken into a positive approach by one of the hospital. What they did, as you know, it costs, that every test costs, especially expensive tests, the hospital wants to cut down. What they did is whenever a doctor was supposed to order a particular test, they used to just flash the cost of that test in front of in the screen. So, they used to make the referring doctor aware how much it cost, and they found out the request, the frequency of the request for particular tests reduced. So, this is how it works, that whenever you have particular information at the time of making decision, it influences your decision making process, whether that information is relevant or not. So, this is what about the availability bias. In the example that I gave, the clinical example that the FY1 doctor didn't diagnose the aspirin toxicity, it also showed the other bias, which is called as anchoring bias. Anchoring bias is the single conclusion is drawn without considering various other possibilities, like he didn't bother to investigate in detail about how many tablets of aspirin she has taken. This is what it happens, that once you stick to particular diagnosis comes to your mind, you don't take enough efforts to find out whether there are any other possibilities, and you stuck to your initial diagnosis or opinion and do not try or tend to go beyond that initial diagnosis, whether it is right or wrong. So, this is what anchoring is. Now, a step further is what we call as a confirmation bias. Now, there are certain objective facts and there are your core beliefs, and there is something in between. Now, if you focus only in this area, you are unable to move your thinking beyond that. You focus only on the facts or the information that agrees to your belief. Same thing happened with the trainee, that although there were electrolyte changes, he didn't agree with that. He didn't think in a different perspective that there may be something else other than viral pneumonia, because it was availability bias, it was anchoring bias, and it was a confirmation bias. There is something called as representative bias. We have been told that if it looks like a duck, if it quacks like a duck, it has to be duck. But there is a challenge to this notion. Here is example. Now, what it makes us is we fail to consider other possibilities. Here is another example. There was a ranger, forest ranger, a 44-year forest ranger who came to A&E with a chest pain. The doctor tried to evaluate if there were any risk factors, smoking, whether there was lack of activity, family history. He couldn't find any. And he performed all the investigations, which came to be normal. So, considering he was a forest ranger, very active, very fit person. There was no family history, so he sent home. And at the same night, he came back with a massive infarct, unfortunately died. Now, when the investigations were conducted, it was found out that it is known that there is particular window period in which the biochemical markers of the infarct cannot be obvious. So, usually they recommend to do the test again after a particular period. What happened in this case is that because the individual was representative of very fit, healthy adult, the doctor did not consider that he might need repeat testing after a few hours. So, this is one of the what is called as representative bias. Obviously, we all know that some things become clearer in hindsight. So, we feel that yes, I did know this after the incident has happened. And there is another interesting case, because there are so many trivial things that may not be related to the clinical matter do affect decision. Here is a study which was done. A 67-year-old patient suffering from osteoarthritis have taken most of the medication but was not getting better. So, the doctor was considering to refer him to orthopedic surgeon. Now, just before he was about to refer, he realized that the patient wasn't given one particular medication. Now, the question was asked to the doctors whether would you refer the patient to orthopedic surgeon or would you try the medication. 53% said that they would still go ahead to refer the patient. Now, another scenario that was put forward to them is that instead of one medication, there are two medications that has not been given to the patient. What will you do? Now, rational thinking says that since there are two medications that has not been tried, a doctor will think, okay, let me try the medication and then I will make the referral. But in this study, it happened the other way. In fact, more doctors decided to refer the patient to orthopedic surgeon rather than trying. Why? There's something called as when there are too many choices given, people usually avoid taking any decision and rather they went back to the conventional mode. So, these are the, who would think that just having one more medication for a choice would change the decision, but this is what it has happened. So, these are the kind of, I wanted to give a kind of gallery of what kind of different biases one can encounter in their clinical practice. What can be done? Now, this is the slide which shows that if you don't address the bias, what will happen? And if you do address it, this is what you will get the optimum clinical decision. How can be done? How can one do debiasing? The first thing is that, and by the way, after reading this book, I have received various sort of feedbacks from the trainee, and one of the trainees said that he found this book helpful particularly for solving MCQs. So, those trainees who are appearing for the exam, they might consider, and as you know, there is something called as MCQ technique. Even though you may be knowing factual information, some of the trainees are unable to answer MCQs, and what I have found that it is because of this bias thinking or inaccurate thinking. Once you refresh your thinking process, it might be helpful for you to answering the MCQs correctly. So, how can you use this information, this process, cognitive process for improving your diagnosis? The first thing is that think yourself, what has been my first impression? And as you know, you might be told as far as the MCQ preparation, that always respect your first hunch, that whenever you have the various stems, what comes to your mind for the first time, may be the right answer. Secondly, sort of consider various options that you have in mind and have elaborate decisions with whatever the various options you have considered. Especially mindful if the decision has been taken under stress, fatigue or time pressure, because that is the most vulnerable period where you might be committing that error of judgment. Now, what are the things that you should be more mindful of, considering what might have gone wrong in your decision making process? If there are too many disparities in their clinical opinion, if you discuss with others, if someone else, colleagues or senior colleague express their different opinion, you should be mindful that it may be that your decision process might have been affected because of the bias. Follow-ups are very helpful. If the progress, the clinical progress is not going according to what you expected, you need to review your decision making process. Now, theoretically or ideally, morbidity and mortality rounds are supposed to give you a feedback, but as someone has said that instead of brainstorming sessions, sometimes morbidity and mortality rounds become a blamestorming patients, and rather than giving a genuine feedback about our thinking process, it becomes a kind of defensive situations where you are supposed to defend your stance, which is not very helpful for improving your decision making or cognitive process. That's why there is a process recommended as cognitive autopsy, and which you can do it either yourself or very sort of people who are close to you and with whom you can confide the diagnostic process or how things have gone. So rather than focusing on what decision you have taken, whether it was a right or wrong decision, if you go through the process, why you took that decision, what were the circumstances that made you to take the decision, and if you get a feedback, that would be helpful for you to improve your diagnostic process. So I would urge you to consider evaluating your decision, and I'm not here to promote my book, but if anyone is interested and anyone wants to have more detailed information about this cognitive decision making process, they're more than welcome to go through this information. And again, I would like to thank you for asking me to come here.
Excellent. Thank you very much indeed. I know that Professor Flynn's got to get back to Aberdeen, so we won't have any questions now, but hopefully we'll have a quick round table before you disappear and we all depart. So I'd be delighted if Professor Rona Flynn could come and join us up here. Professor Flynn is originally from Glasgow, moved to Edinburgh, Aberdeen Business School rather, and moved into the field of industrial psychology, and is a real global leader in human factors and organizational cultures, works with big oil industry, and has a great interest in high-risk industries of all types, including surgery. She works alongside the Royal College of Surgeons of Edinburgh and runs a human factors course and examination for the Royal College of Surgeons of Ireland. She's a very illustrious guest, and thank you very much for coming to speak to us.
Well, thank you very much for the invitation to come down here as part of your training program. And what I'm going to talk about will complement, I think, the previous talk, because that's also my area of interest. My sort of broad area, I'm a cognitive psychologist by background, and my broader area of interest is working on safety in higher risk industrial settings. The interest, I think, of starting to bring psychologists into your workplace, which really didn't happen until very recently, was a bit different from some of the other sectors where they're concerned about high risk, such as the aviation industry, nuclear industry, oil and gas to some extent. And one of the things, of course, that interests us when we look at safety are not just trying to understand what makes good practice, which we're primarily interested in, but what happens when things go wrong. And that's an area you probably know more about than I do. Great famous historical cases of surgeons, very skilled surgeons, but we talked about learning curves and things not always going well every single day. Yeah.
Something's happened. can't do this.
Oh, yeah.
If you want
Okay.
to, might use the keyboard actually.
Yeah, okay. Okay, so modern cases, surgery improved dramatically. We've heard this afternoon, I'm sure you heard this morning, all kinds of very exciting new developments, but there's clearly occasionally a bad day, things don't go quite so much to plan. And recently people have begun to take an approach that's been taken in other sectors by trying to understand what's called human factors, which is a multidisciplinary subject involving psychologists, ergonomists, engineers, designers, looking at how humans react with their work environment, whether it's the technical environment, the heat, the light, whether it's the equipment you're working with. Psychologists are particularly interested in the individual, how they work in the team, but there's also stuff about the organizational culture. Does that encourage risk-taking? Does it encourage caution, etc.? So there's a multitude of factors there. And the piece I've been working with surgeons on for a number of years, it's an approach that was used in aviation. It's been used in aviation for 40 years. It's still a key part of the safety management systems in aviation, and that's trying to understand practitioners' non-technical skills. This is their cognitive and social skills that contribute to either enhancing performance in a safe direction or starting to increase risk in terms of the operational procedures. So this is the piece I'm going to speak a little bit about. And I'm not going to go through all this work. Some of you, I don't know how many people are familiar with this term non-technical skills, or whether it's coming in now a little bit in surgical training, but I worked on this topic initially looking at non-technical skills for European airline pilots. I say it's a big part of their world. And then starting to work with anaesthetists and surgeons and scrub nurses in Scotland, there was clearly an interest in looking at whether any of this applied to your world. Thinking skills are, as we've heard all afternoon, a very important part. Decision making, situation awareness, and then these skills around leadership and teamwork, which had not been trained so formally in your world for what actually happens when you're in the operating theatre. The term that's used in aviation is called crew resource management for this type of training. And effectively, to do this well in another industry, another sector, we need to not just take things from aviation, and I'm well aware that surgeons are very bored about hearing about the wonders of pilots' performance, but we have to go back and do the task analysis and really try to understand what are these key thinking skills, what are these behavior patterns, what are the conditions in your workplace that affect them, and then we can identify these skill sets, and then we can look at how we can build these into training, performance assessment, into M&M meetings, whatever. If these are factors that influence surgical outcome, then we need to start studying these in a systematic way. And the red arrow represents what I see sometimes happening in industry, and certainly happening in the NHS, where we say, oh dear, we say this 10, 15 years ago, patient safety is a problem. We're seeing London data, 10% of admissions have some kind of adverse event, 50% of these are preventable. What are we going to do about it? And people say, well, it's something to do with human behavior, teamwork. We'll just get some airline pilots in and they'll give us their training course and that will fix things. And that's clearly not going to work if you don't have the evidence base on which to design your training. So the question is, was any of this stuff that was being used in industries applicable in your world? Prior to about 2000, 20 years ago, there was very little work, or very few psychologists being allowed into operating theatres to watch surgeons' behaviour. And the piece of your work that I'm interested in is what happens really from knife to skin to closure. So I know there's a whole lot of other very significant pieces of your work to do with clinics and diagnosis and post-surgical treatment, but the bit I'm interested in is what happens while you're operating, while you're on task. And these data sets, preliminary, and there's more of them now, began to look at what role non-technical skills played in successful outcome and what role they played when there were adverse events or poorer outcomes for patients. So we worked on a number of projects in Scotland to identify what were the non-technical skills for surgeons and the other practitioners they work with in the operating theatre. I'm not going to go through all this stuff. There are websites on this, there are booklets. If you're interested, I'll give you my email at the end and I can send you the booklets that explain this material. What I'm going to do is take one piece of that and look at decision making as part of the issue. So the framework of non-technical skills for surgeons, which I'm sure a number of you have seen, has decision making in there as a key component. And these frameworks came from interviewing surgeons, doing lit reviews of your data, of observing surgeons, working with panels of senior surgeons, many of them general surgeons, to have them tell us what were the key non-technical skills as they could see it. And clearly decision making is a great big part of that. So we have a number of elements here, considering the options, or one option if you're going to be using intuitive decision making, communicating that, there's a team piece here, and then implementing and reviewing that decision. And your literature, there wasn't all that much on intraoperative decision making, but what we could see was reinforcing the idea that this was important. This is a little bit, it's hard to find examples of surgeons talking openly about, they probably do in a forum like this, but to get an insight on how surgeons make decisions. It's quite difficult from your literature. There's lots of technical stuff about do this, watch for that, do the next thing. But actually, for a psychologist, trying to get a sense of what's it feeling like when you're making decisions, particularly in trickier situations. And this is a little quote from Marsh, a London neurosurgeon, who is operating on an aneurysm, talking about how he feels when he's dealing with this. But he's already in this example been a bit frustrated with the trainee. Maybe you've been in this situation because the trainee doesn't seem to be working the applicator properly. So he takes the applicator, he takes over controlling the applicator and then finds, the applicator's not working. They've got this in position, and now it's not, I can't move my hand for fear of tearing the minute fragile aneurysm off the middle cerebral artery and causing a catastrophic hemorrhage. I sit there motionless with my hand frozen in space. These are the kind of moments that are very interesting if you're trying to understand what does it feel like making decisions and what's going on in the surgeon's head and what do we do to develop skills to deal with this kind of situation. He goes on, this is in his book, Do No Harm, which has got these examples in it. So the threats for intraoperative decision making are considerable. This is based on an interview study we did a number of years ago with surgeons, asking about decision making in theatre while you were operating. And there's a number of things that come through here. A lot of it is to do with patient factors, and we've heard already how unpredictable that anatomy can be. But other factors there, visibility, who you're working with in the team, for example. So these are the kinds of things surgeons talked about when we asked what influenced decision making. But there are other threats I think we can look at, and it maybe goes back more to the previous talk. We've got issues here about decision-making skill as well as your psychomotor skills, and also the little bit of work we've done on how surgeons make decisions while they're operating immediately starts to surface the issue of risk judgments, risk perception, risk tolerance, potentially personality differences in risk tolerance. How much risk are you comfortable with? And I'll come back to that, because in some ways that's more interesting than the actual processes of decision making. This is some work by a Canadian team in Toronto led by Caroline Moulton, who's an HPB consultant surgeon who's done a PhD on surgeons' decision making, and she does really interesting work. And this paper talks about avowed, unavowed, and disavowed reasons that can influence your decision making. So again, asking surgeons why they made a particular decision, why did they do a particular operation, why did they convert, or why were they slow to convert in a procedure. There are things that values underneath there. Of course, patient well-being, everybody's very happy to talk about that. But underneath that, maybe there's some other things. I was under a bit of time pressure. I needed to get this finished. I was teaching, so I didn't want to convert too early because I was trying to show this. I did an interview with a surgeon who told me very honestly he had visiting surgeons from halfway around the world watching a procedure, and maybe he continued a little bit longer before he converted as the problem started to arise than he would have done if they weren't there, and clearly thought about that in retrospect. And then there's some stuff that's really not okay to talk about publicly, and maybe this doesn't affect so much in the UK, but what's the financial gain for doing one procedure or another? Or what's the cost to my reputation here if I proceed with this very difficult procedure, etc. And as I say, this stuff is only beginning to be explored in your world, but it's quite interesting, and it's there. You're not immune to those kinds of biases, values, feelings in your decision making. So, as we heard already, decision making effectively, particularly if we look at the work in naturalistic decision making, which is a whole field of work that looks at how do experts make decisions in the real world. So this discounts a vast amount of decision making literature that studies how students or other people make decisions when they've got all afternoon to think about a problem and there's not really any consequence. This field of NDM, of naturalistic decision making, and some surgeons come to the meetings on this, is about how do you make decisions in the real world when there's high risk and there's time pressure and there's an organizational culture and all those other things. And this work has shown that for many of these domains, the focus is much more on how do you read the situation in the first place. This is a big hallmark of expertise. And from watching these videos, particularly all that, finding your way through the terrain, this recognizing key cues and what do senior surgeons see in that environment of tissue and vessels and things that are lurking under other things that the novices find much more difficult. That's a big piece. And when you're doing that stuff, what's going on is a calculus about time and risk. Maybe time there is a time pressure there. I think even though you say there's not, you may know there's a list, you may know you'll have to cancel another patient. There are probably time factors, but there's certainly a risk calculus going on there. And then there's the piece that all drives the process of deciding what to do. And those biases are lurking in there somewhere. In terms of the cognitive architecture, I'll not go through this in detail. The bit that's really interesting here for task performance is understanding working memory, which is the kind of conscious working space, which we know has a limited capacity, is very prone to interference, and is also prone to because it's got a limited capacity, new information coming in will displace old information that you're currently thinking about. Imagine doing mental arithmetic or a calculation. That's really taking heavy use of working memory, even though you're pulling information up from the much larger stores. And I think understanding working memory, and also we've had conversations with surgeons about not just protecting their own working memory, but thinking about other people using working memory. So when does the music get turned up, or when does the music get turned down? Does the music get turned back up? The surgeon's music, if the surgeon has chosen the music, when the anaesthetist is trying to bring the patient back from the anesthesia and the scrub nurses are counting. And mental arithmetic and music don't go well for a lot of people. So there's like things about everybody in that theatre's got a working memory that may need to be supported. There's models, I'm not going to go through all this, but if you're interested, there's a whole literature on working memory. And from some of the work we did with nurses, scrub nurses, it's quite interesting thinking about, even though surgeons have high mental capacity, they are working on the same architecture, they're working on pretty much the same kinds of limitations. And I've heard in other medical domains now much more discussion, emergency physicians I heard talking recently about cognitive bandwidth, about being very conscious about how much information you can be holding sensibly at one time. And that's a kind of topic on its own. But this is scrub nurses talking. When surgeons ask for something and you give them what you think it is that they need, it's not the thing they said, but you know it's what they actually want. It appears that surgeons are quite happy with this behavior pattern in nurses that they trust. Another example, surgeon having nominal aphasia now in the middle of the procedure, asking for the buzzy thing. Fortunately, experienced sub-nurses know what the buzzy things are, one assumes, and give them the right piece of kit. But this is a surgeon who's got a working memory now already completely overloaded, potentially trying to hold a lot of information in your visual field and then having to retrieve a name from your long-term memory. So I think some of these things have been very little studied in your world, and anybody's looking for a project, these might be some ideas to think about. We heard already there are these different modes of decision making, these different ways, this particular contrast between this fast, intuitive, and then the much slower analytical. What will I do now? 3 different things. I need to weigh up the pros and cons. Clearly in choosing procedures and selecting procedures and how you're going to do the procedure, there's a lot of that. But when we listen this afternoon to experienced surgeons going, I do this and then go here and then look, it makes it sound to me very easy. It makes it sound very intuitive because I'm getting the signal, they know where they are, they know the next bit, they know the plan. We heard the talk of roadmap. For a trainee surgeon, less familiar, there's probably a lot more analytical thinking going on at that point. And of course, this is running in cycles. The little bit of work we did looking at how surgeons make decisions, we interviewed surgeons, we asked them to talk about a challenging moment in a procedure, and we were just interested in what kind of decision making they seemed to be using at that point. And the indications were about half of them talked about situations involving analytical decision making, very slowed down, very conscious, maybe thinking about options. And in other cases it was, maybe because it was high time pressure, I just had to recognize where we were and do the most obvious thing because there wasn't an opportunity to do any other kind of decision making. So there's a literature emerging on this, and as Utham has said, surgeons are beginning to get interested. And as you move across these styles, as already heard, stress has a different impact. This is why experts who have less stress in the first place, the intuitive fast, I know where I am, I know what I'm doing next, is less prone to being diminished by stress than the analytical decision making. It's a bit of a double whammy for the novice who's using the analytical decision making and is more likely to be experiencing stress while they're doing it. And part of the reason this stress causes you a problem is because it's taking up some of your working memory capacities. You've got less space to think about things because you're already experiencing anxiety. I'll not go through this. This is what I mentioned about surgeons talking about different kinds of decision making. Didn't seem to be terribly relevant to these factors, but one of the things that came through that we weren't particularly looking for was this talk about assessing the threats in the situation. This is an operation situation, trying to judge impact of actions, and this how comfortable, surgeons often use the word comfortable when they're talking about this kind of decision making, how comfortable or uneasy they are about that. And that might be an interesting metric to get in and start to understand some of this. Some of you may have looked at this work, Kahneman's work, psychologist who won the Nobel Prize, looking at this fast and slow thinking. And this is this intuitive, rapid, know where I am, know what I'm doing, know the next thing, very automatic process against the analytical. Moulton, Carol Ann Moulton, who I mentioned, these are some interesting papers, and some of you may have seen them, but this is about understanding when you should switch from one style to the other. And in some ways, this is a really interesting question because you clearly use different styles of decision making. But the key question is, how do you know when to switch from doing, yeah, all going fine, to, whoa, we need to slow down here and think about this. And this is part of her doctoral work, watching surgeons, interviewing surgeons, and watching when do they do this, what are the expert novice differences here. This is a quote. We did a book on known technical skills for surgeons, and from part of the data sets we had this example. There's a consultant talking to a trainee. Where's the hole? Can you see it? Well, that's no good. If you can't see the hole, we can't repair it, can we? If you can't see it, we have to put the clamp on. Another vascular clamp, please. Right. Think. Let's just think here. This all started off so nicely, didn't it? So this was clearly a routine day in theatre. Things were going well. And now, for some reason, not the anatomy you expected, somebody has put a hole in something that wasn't supposed to be there. And the key bit for me is this coming off this, slowing down, and then literally saying, let's just think here, is moving into this mode. Molten is examples of where senior surgeons notice suddenly the need to slow down, and the trainee is still carrying on, having missed the cues, because there's cues in the environment, in your visual field, that are telling you, it might be a cue from the anaesthetist or blood loss, but probably it's a cue in the anatomy that's telling you. And she also talks about this concept related to the same thing, surgeons carrying on when they should be slowing down, ploughing through, she calls it. There's a surgeon saying, I think this is the other time you get burned, it's the easy ones, because the difficult ones you're going slowly all the time. And that's exactly what happened here. An easy lobectomy, not going slow. You're maybe chit-chatting because you've got space in your head to have a bit of a chat as well. And now you're not paying as much attention because you've dropped your guard here. And now something adverse has happened. And we see in aviation, this is work from NASA, the same kind of thing. And I've talked to surgeons about this as to whether this could happen in your world, where the goal, the end of the task is so seductive because you're nearly finished. So you just want to keep going. And I think if we looked at when do people make conversions or hadn't converted when they should, maybe that's one of the things. This is a study with pilots in the simulator, increasing the amount of risk and finding the nearer they got to the destination airport, the more risk they're tolerating. So the question is, because this happened, the nearer you are to getting this finished, and you might in your world have been at it for 3 or 4 hours and spent weeks planning it, you know, to abandon that procedure or even just change the procedure, which is very labor intensive. And again, we're beginning to go into personality factors here about how much risk is being tolerated by different people. And just to finish with another couple of ideas we're seeing in the safety research field that I wonder if they're relevant for you. We did some work for Shell, the oil company, recently looking at chronic unease. They were running a program on this. This is after the Deepwater Horizon. You might have seen the movie, oil accident, where the drilling rig in the Gulf of Mexico suffers a severe blowout, killing, I think, 11 or 15 people. And anyway, huge oil spill, great problem for the oil industry. And what the companies are concerned about is complacency, particularly when things seem to be going okay. The point is, if you're working in a high-risk environment, as you do, you can't ever afford to be complacent. You can't ever afford to be too comfortable. And this concept comes from the high reliability organization literature. And I just began, we've been looking at this in industry, but I just wondered about your world. And then I saw this head and neck surgeon earlier this year in the Times, who was being interviewed. I think it's one of the ones who was being followed about by a BBC crew or a channel, saying, sometimes I don't switch off, I think about patients, I wake up, bolt upright at 2 a.m. remembering something I've forgotten. I'll send an email. And maybe there is something about having a requisite level of anxiety, and what should that level be? I'm only throwing this out because I'm not even sure if it's applicable in your world. And I examined a PhD earlier, I can't remember, end of last year, beginning of this year. It was from the world of aviation maintenance, very important world for any of us who fly. And it was on a new concept called latent error detection that they were working with in military aviation. And Sayward was the PhD student who was an RAF officer, an engineering officer. Stanton's his psychologist, his supervisor. A really interesting study about people remembering about errors they've made 2 or 3 hours after the task has finished, driving home, sitting in the coffee room, suddenly going, oh, Did I do that? And I've only presented this idea a couple of times, and I see I've got quite a lot of nodding. And one of the surgeons I work with said to me, oh, I'll tell you when you get that as well, is where you mean to do, you've got a major procedure, but you're going to do something small, I don't know what, take out the appendix, or do something that's not the big procedure while you're in there, and you're so busy concentrating on the great big thing that you've been worried about and you've got done, and you close up, and then you go for the, and go, oh no, we were going to take, I don't know, the gallbladder or something while we were right in there. You know, not common, but would sit in this kind of domain. And the question they're posing is, what are the cues that help you do this? Are there some techniques they should be teaching about just taking a minute or two to reflect on the whole task? Maybe in your world, pre-closure. In terms of, was there something else? Anyway, sorry, this is a bit of a whistle-stop tour. The other thing that might be affecting decision-making, I'm not going to discuss this, but I see the College of Edinburgh in particular, the Australian College as well, RACS, whole lot of stuff going on bullying and atmosphere and culture and belittling behaviours. And my question here is, of course, what does that do to decision making when you're in that kind of culture and you're trying to work, particularly when you're a trainee? These are not nice behaviours, but they have cognitive consequences as well. So my emails are there if anybody's interested in any of this stuff and wants any references or information or wants a copy of the NOT stuff, then please just email me. Thank you for your attention.
Fantastic. I mean, that was absolutely brilliant, and I think certainly for me, and I think probably for everyone else in the room, there are some serious bells ringing there, and it's amazing how much insight you've got from the work you've done. It's terrific. You've got to go and catch a plane. I suspect it'll be much easier, much less stressful for you if we maybe asked a few questions now. So I suspect there'll be some questions from the floor rather than waiting around, because, yeah. Michael.
As a surgeon reaching the end of my career, I loved your talk. We have a room full of trainees. Allow me to add one element, the 7 Ps of surgery. Proper preparation and planning prevent piss-poor performance. And you have to think about what you're going to do. We have some very experienced surgeons in this room. And sometimes we're facing an operation and we know where the difficulties are going to be. We think about it, we plan for it, and we each all have our special moments to do that. Me, it's my shower in the morning, it's when I'm cycling to work. Everybody functions in a different way. What's yours, Ian?
I'm not sure. I think a mental imagery, mental practice of what I'm going to do.
And thinking through the key steps. These are the anticipated difficulties, and this is how I'm planning to measure. And then you get into the operating theater, and it all changes, and we have to adapt and change our strategy. But if you haven't planned to start with, you're a right-hander operating with your left hand. Yeah.
And what you're doing there, I think, is that you're using these more analytical, heavy-duty thinking techniques when you've got time to do it, and maybe you have a bit of paper and a pencil. I don't know. People do these things. This mental prep stuff is clearly very important for surgeons. And what that does is that allows you to do the faster intuitive stuff when you get in there, because you've pre-thought, and you've also probably got some of these, you've pre-planned some of these slowing down. You could hear when you were talking, the bits you think was a bit of a danger zone here, be very careful. And I interviewed quite a lot of people at decision making. I interviewed Sandy Woodward once, who probably not everybody remembers this, but we had a bit of a conflict with the Argentinians a number of years ago and had to send a task force down to the Falkland Islands. And I talked to him and some of the commanders about their decision making. And one of them, it was him or one of the other ones, told me that what he did on the way down to the Falklands when they had sailing time was he did what-ifing all the way down. You know, like, what will happen here? What if that gun fails? What if this doesn't launch? What if we get hold here? Because he said once a battle starts, there's no time to do any of that kind of decision making. I have to do my what-ifing beforehand so I can do the fast stuff under battle conditions. And I guess sometimes it might feel a bit like battle conditions on a bad day in surgery, where you're kind of almost feeling like you're working with an adversary and trying to get the better of that whole complexity of anatomy.
Hi, I have so many questions, but I'm going to try and limit them. Focusing on trainee things, risk-taking in surgeons, you said, was interesting. How does that show itself in trainees? Are there just different personality types, and does that affect how fast they learn things? Does that affect how well they make mistakes? Do you have to change your attitude as a trainer? I just thought, and I mean, there's a convention that girls tend to be much more risk averse than boys. That's a massive gender stereotype. But my experience, having gone through most of my training now, is we definitely start off being like, oh, I can't do that. Maybe you could show me again. And it's not until we get much more experience, we get more confidence to be like, actually, I can do this. So, yeah, how do you pick out the risk aversion or not?
Yeah, I think there's masses of stuff there, because you've self-selected into this profession in the first place. So there's a whole lot of people well, a lot of people don't want to do medicine in the first place, and there's a whole lot of people in medicine who don't want to get into your world, and some of that is going to be a personality factor. I don't know, I don't have a quick answer to this, but I think working with trainees must be quite a lot of making fine judgments about risk tolerance, and all the time, you know, if I watch in theatre, there's this pushing the trainee a bit forward and it's this comfort thing, and the comfort's based on your knowledge base to some extent, because you're uncomfortable often because you think, I don't have the expertise, I don't have the knowledge, I don't recognize these planes or pieces. So I think in factoring that into the training, but actually doing some personality work around, you know, risk taking and risk tolerance, and you need high risk tolerance in your world. You're taking a lot of risk on behalf of us, the patient. So you do need to learn to be comfortable with risk. So there may be things for other industries, other professions, about how do you learn to be comfortable with risk. But yet I think you still have to retain this chronic unease a little bit. I don't know, I don't train surgeons, but I'm not sure you want your trainees to be too comfortable, do you? I'm looking at the...
I think it's although it says chronic unease implies a pathological aspect to it,
Yeah.
because there's some healthy sort of realism.
Skepticism, or... Yeah. I know, I don't like the terminology, but anyway, it was
I think trainees are all different as well, and actually as a trainer you've got to gauge that, and the shame about what we have at the moment is you don't always get the same trainee regularly enough to be able to push or slow down, so it can be a very individual thing there.
I'm very uncomfortable for both parties, I guess, through a lot of that interaction.
You're going to ask
Sorry,
a question.
just,
I really want to ask a question.
No.
It sort of follows that. This is a really big area, but I was thinking about where you think there is a big trade-off at the moment between European Times Directive and pressure of time and tiredness, how that affects performance, and the dismantling of the team, which all of us more senior people really found that a very valuable part of our training, and it was a stimulating factor which galvanised your intent to learn, working together. It was a very human experience with other people. It's a ridiculous question to ask in some ways, but do you have a feeling of whether that balance has moved too far in terms of individual protections and tiredness and individual factors at the expense of those cultural things?
Yeah, I don't know. I mean, it's a fine line. The tiredness thing and the working hours some people were doing, I think, were probably pretty hazardous, but it's a really interesting trade-off in your world, and I know a lot of senior surgeons are very concerned about that reduction in training time, and trainees concerned about not getting enough
And just taking out
practice.
human interaction, which is such a key part of what we do, not just between doctor and patient, but doctor and doctor.
But it may mean that we have to look at understanding what some of those support mechanisms were, and looking at how they can be built back in some other ways into your world. And I think trainees create a lot of their own support mechanisms, and maybe we need to look maybe more about how effective that is.
Sorry.
Yes, okay. I guess on the other side as well, so inevitably we will cause harm to patients, people will die. What would you say are the best features to stop being burnt, casting a big long shadow over everything you do after that?
Yeah, it's a good question. I don't have a good answer, and I think it's just something that hasn't been looked at very well. I think you were just left to burn out in the past often, and I think I do see much more of a conversation about that. Yeah, being able to.
Yeah, I was just going to say, to follow on for that, I think some transparency and being able to discuss problems, mortality, morbidity being more open than it has been in the past, and also embracing the problem as a team rather than as an individual, I think shares the load, and I think that probably will make it easier to avoid burnout in the future. But that's only an anecdotal sort of.
And surgeons talking more publicly about error, which we have seen, and that's good for the public. I mean, it's fine being treated like superheroes, but actually, it's maybe important the public actually have an understanding.
And that's a culture change that needs to happen.
Yeah.
We have to be more confident to acknowledge the errors that we've made.
I was actually just going to come back to your question about training time, which fits in with something else I was saying. Was thinking after your talk, turning that intuitive knowledge that you have as a consultant and working out how to explain it to a trainee, I think is quite difficult. And I think the TME talk was amazing. I don't know if anybody else found this. I've never had anybody stop and name every single part of the operation and every bit of the anatomy. And how do you get experts to turn their intuitive knowledge into something they can explain?
Well, maybe the kind of way you're saying is just like teaching somebody to drive or whatever, trying to deconstruct it and break it down. What interests me when I hear surgeons talk, or when I see surgeons doing live feed when they're actually operating, is that there's all these little tiny micro decisions all along the way. Put in another stitch, push this bit a bit further, and we did get quite a lot of that today, but I don't know, everybody's looking at these tight, because I think what are micro decisions to the expert can be quite big decisions for the trainee. Like, it's not really obvious why you're doing all those things, and I think we got quite a lot of that why uncovered.
Right, this is generating a lot of discussion. Fantastic.
It's actually more complex than that, because I'm a thoracic surgeon, and there are parts of the anatomy of the lung that are extraordinarily unforgiving. A pulmonary artery in an 85-year-old woman is an extraordinarily fragile structure. And there are things that if you were my trainee, I could explain to you. And there are some things, I'm afraid it really is, as you get more experienced, I can tell you all the things. Every time I pushed here when I was at your level, there was a hole and it bled. And now I do the same thing, there's no hole, it doesn't bleed. You do acquire, with training, a sensitivity to what the tissues will tolerate. And you also, one of my mentors said to me, and it's interesting because as we get older, we're different generations, we're fitter, we're different than people before us. He was about 62, 63. We were doing a third time hiatus hernia repair. You guys all know what that's like, yeah? And he said to me, when I was 55, I actually hit my peak in technical excellence, but my operating times have stayed the same because now, with the extra experience, I know even better exactly where to go, also where not to go, yeah? And these are some things that you cannot teach. You just have to acquire that experience. But there are some things I can teach you. Turn your scissors the other way around. Have the blunt side of the scissors against the PA, not the sharp tip. Those are the sort of things I can teach you. But the experience of tissue tolerability, that knowledge, that intuitive knowledge of where to go and where not to go, I'm afraid that takes experience. Coming back to the firm structure, at the Brompton we still have a firm structure. And I can tell you the trainees love it to bits because it's novel to them and they find it extraordinary. I'm Swiss, I trained on the continent, okay? We didn't have a firm structure there, but you have trainees that spend many years in the same department. So you get the same sort of familiarity. I would know you, you would know me, the same as we do here with a firm structure. The problem in Britain is you've got a mix and match of both, and it's an unhappy marriage. The last thing is, we were talking about selection for surgery, and you said self-selection. And it's the one thing we always forget, because there are people in the European Society of Cardiothoracic Surgery that say, you know, we can train a fighter pilot to fly a $50 million pound jet in 3 years, and we can't train a cardiothoracic surgeon in 6. Yeah? Well, the analogy is completely false, because first of all, they have thousands of applicants, and they have done the psychometric analysis of what makes their best pilots, and you don't fit the profile, you don't get in. It is that simple. Whereas we don't even know truly what makes surgeons tick. And in cardiothoracic surgery, the presidential address of the Society of Thoracic Surgery in the United States back in the late 90s was, guys, we have 130 training positions and 110 applicants. So even if we did know what made us tick, we still couldn't do the selection on the basis of who's most suitable, because when you're scraping the sides and the bottom of the barrel, you take what's available, yeah? And that is a reality, whether we like it or not, but it's a reality nobody wants to address and talk about.
Thanks very much, Michael, for those cheery words. Excellent. Anyone else have anything to ask Professor Flynn? Right, well, that was a fantastic talk. Everyone really enjoyed it, and hope you might come back if we run it again. Thank you. So finally today, everyone's probably running out of steam now, is Mr. Dusmet, who's a thoracic surgeon at the Royal Brompton Hospital. He's been there for 15 odd years now, and before that grew up in California, trained in Switzerland, and spent some time in Toronto. So we look forward to his talk on pulmonary metastases for the colorectal surgeon.
First of all, on the desktop, I've left the PDFs of 4 of the key references if you have any interest in them at all. And they're not highly specialized articles, they're review articles. Pulmonary metastasectomy, and I'm going to focus obviously on colorectal cancer. You're not interested in metastasectomy for sarcomas. You all know these numbers. 50% of patients with colorectal cancer will develop metastatic disease. Somewhere between 5 and 15% of those patients, it'll be in the lungs. And like I said, I'm going to focus on what you're interested in, not what sometimes floats our boats. Although I do think this is an interesting topic, fascinating. The basic premise of a metastasectomy is that we are assuming that there are truly patients that have a finite and limited number of metastatic deposits. And if you treat these metastatic deposits radically, you will contribute to the cure of their cancer. That is the basic premise of the whole principle of metastasectomy. I don't know if any of you have any interest at all in thoracic surgery, and in particular a funny disease called myasthenia gravis. But for years and years and years, thoracic surgeons have been accumulating a huge body of evidence, and we have been claiming high and loud that, yeah, thymectomy works. It cures myasthenia gravis in over 1/3 of patients. And some neurologists referred a lot of patients to us, and some said, you're all, never mind, moving on swiftly, keep this polite. And there's finally been a randomized prospective trial in the New England that shows that the surgeons were right. And we're kind of at that pre-randomized trial stage with metastasectomy. There's a large body of surgical evidence, which some people have analyzed critically and says is not worth the paper it's written on. And as surgeons, we do believe in what we do. And we do have buy-in from the oncology community because, after all, they're referring these patients to us for metastasectomy. Yeah? And the PULMIC trial illustrates how this is not universally accepted. And some of you may or may not know the PULMIC trial. It's an extraordinarily complex trial designed by Tom Treasure who is an extraordinarily gifted man. I really like Tom a lot. I have a lot of time and respect for Tom. I think there's one problem in his basic hypothesis, and that's that he was assuming that patients coming for metastasectomy are chemo-naive and there's an alternative to surgery, whereas, as all of you know, the patients that come to me for metastasectomy are very rarely chemo-naive nowadays. But as you can see on this slide, you start off with the patients have pulmonary metastasectomy, and basically the premise is working on a traffic light system. So the surgical community has decided there are patients that are going to do so well with metastasectomy that you cannot deny them this procedure, and they're the ones here in the left-hand panel, and they'll go to metastasectomy. And then in the very right-hand panel, you have the patients where everybody agrees that metastasectomy is a purely futile operation, and then of course in between you have a gray zone. And the idea was that each center could design what their gray zone was, and then enroll the patients into the trial, and they would be randomized to either having metastasectomy or just observation. And the trial also allowed you to say this one patient, he had 5 mets, and so it was too many, and so we randomized him and he's in the observation arm, but we're 2 years down the road and he still only has 5 mets and now we want to operate. You were allowed to do that in the trial, and everybody that was in the trial was in the observation arm whether they liked it or not. So all 3 groups were in the observation arm. The trial is now closed, and now the results need to be analyzed, and I'll have retired before they're published. So what are the principles of metastasectomy? This is surgery, so it always starts with the patient, and anybody who forgets that is asking to come a cropper. So the basic principle starts with the patient. The patients have to be in good condition. You're not doing this in PS3 patients. You want good performance status patients. They mustn't have any life-limiting comorbidities. And of course, because we're doing lung resections, they have to have sufficient pulmonary reserve so that we're not going to make them breathless. Because for me, the cardinal sin of thoracic surgery is to take a well-functioning patient and turn them into a respiratory cripple. And that is the cardinal sin of thoracic surgery. There are tumor criteria. So the primary site has to be completely controlled or will be completely controlled. Any sites of extrathoracic disease can and will be treated radically. So the patient has 1 lung metastasis, they have 1 liver metastasis. It's a futile procedure to do their lung metastasectomy unless you're sure that the liver team is going to radically treat the liver metastasis. And finally, this has to be done with curative intent. The indications for palliative metastasectomy are extraordinarily few and far between, and if you've got more than about 3 to 5% of them in your practice, or even less than that, I'm sorry, you're a cowboy. I don't have strong feelings about things. The basic principle is that all the lung lesions will be treated radically. You've noticed I'm using the word radical a lot, and it doesn't always say surgically, and I will come back to this in a moment. And the aim of the surgery has to be to achieve an R0 resection. I would remind you that the definition of an R0 resection is that all your pathological margins are through healthy tissue. And the other principle is to take out as little lung tissue as possible to achieve this aim. The principal techniques are what is called precision excision, and you literally cut into the lung with a heat device. Some of us are old-fashioned and we use cheap things like diathermy. Some people use newfangled expensive lasers. I like to operate with loops. You can't use a laser and operate with loops. Laser metastasectomy is supposed to be so cutting edge and new. I did it as a trainee in Lausanne, Switzerland in the late 90s. It's been around for a while, guys. It's not new. It's heat, it cuts, both fur up when you got too much blood. I don't think there's much difference. You can do what are called wedge resections. You take a stapler and you staple out a wedge of lung tissue. And you can do anatomic resections. If you do have any vague souvenir of lung anatomy, there's the whole lung. It's divided up into lobes, 3 on the right, 2 on the left. And the lobes are divided up into segments. And you can do, and if any of you have seen your general surgeons, if any of you have seen any liver surgery, well, you're used to what segments are. Well, we have the same thing in the lungs, yeah? Should it be done as an open procedure or a VATS procedure? When I was a young trainee, there were still people that said you had to examine and physically palpate both lungs. I think that's gone, dead, buried, and thank God. We now have much, much better scans. We're used to working with volumetric CTs with 1 millimeter cuts. You see reliably nodules that are 2 millimeters in diameter. We have much better planning of our procedures nowadays. You only need to operate on the side where there is disease. And the other debate was how many, if there were people that did a VATS metastasiectomy converted to open and then looked how many extra lesions they found. We're dealing with colorectal cancer today. We're not talking about sarcomas, okay? Different courses for different horses for different courses, yeah? Manual palpation is probably not as critical in colorectal metastases. But there are technical aspects. With a precision excision, you're taking out a lot less lung tissue to get deeper seated lesions out. And I think that is important. It's one of the key goals. So personally, if you have a single met that's really at a corner of the lung and it's really easy to do a VATS wedge where you're taking out no more lung tissue than you would open, I think it's a very good technique. And again, I'm not going to go into the whole debate about VATS surgery versus open. I just want to remind you one thing. I'm a dinosaur. I've already admitted that. I've already told you I'm getting to the end of my career. And I'm also, in lung cancer surgery, I'm a total anal retentive, obsessive compulsive lymph node dissector. And I think there are extraordinarily few surgeons that with a VATS camera can take out the nodes the way I do with open surgery. All my cancer lobectomies are open procedures. My operative stay has been pegged at 5 days for the last 10 years. I can't seem to get it down. Last governance say they told me it was 4.5 days. It's going to come back to 5. I do not live in, I coined a new phrase at the European meeting this year. I called it Walt Disney surgery. Yeah? And you had a brilliant example of some Walt Disney surgery when there was a critical review of some of your literature just a few minutes ago. Yeah? Let's live in the real world. Yeah? Bristol, you're a good British unit, has just published their stay on VATS lobectomy, 5 days. The god of uniportal VATS has just published his results in the European Journal, average stay, 5 days. I use on average 2 staplers and a lot of ties, and a very high percentage of my cases are teaching cases. How are they paying for the staplers with the extra staplers they're using with the same hospital stay? Moving on. So let's not focus on the size of the hole we make. Let's focus on what we do inside the chest, yeah? And the goal is to do the best metastasectomy we can, and you'd make the hole you need to do the proper procedure, yeah? Chemotherapy, just a quick slide. Very few patients, like I said, are coming chemo-naive. The ones that are usually where there's a diagnostic and therapeutic issue at the same time. Would you please take out this nodule? A, so that we can know what it is, and B, so that we can treat it. And there is often, you've got a 65-year-old guy that smoked 20 a day since he was 15, and he's got new nodule in the lung. Let's face it. Just because he's got colorectal cancer doesn't mean it's a metastasis, because it might well be a new lung primary too, yeah? So sometimes the issue is diagnostic, sometimes it's therapeutic, and the decision whether they should have chemotherapy first, surgery second, or the other way around, quite frankly, this is not my field of expertise. That's why you guys have a colorectal MDT. You're the experts, you're the brains, I'm the hands, okay? Let's keep it simple. There are multiple series in the literature. I've left you the PDFs of, first of all, what the pulmic trial is all about, if you're interested, and secondly, 3 review articles on metastasectomy. The one I like the best, of course, is the paper by Gonzalez, because it comes from Lausanne, Switzerland, and that's where I come from, and the senior author is Hans-Beat Ries, who is one of my major mentors. So, of course, that's the best paper. But I've given you all 3. Yeah? Basically, the average ballpark 5-year survival figure for pulmonary metastases is about 50%. I'm not going to tell you it's 52.5% because you don't remember that. 50% is a nice round number that you can retain, yeah? And it's a good ballpark figure. So what are the key prognostic indicators? Who does well, who does badly? Disease-free interval is the first one. The ideal patient will have a 4-year disease-free interval, and then they've got a solitary lesion, and you take it out. That's perfect. But you also have patients that present with their metastases at the time of the diagnosis of their initial cancer. And synchronous is less good than a long disease-free interval. The definition of long is, of course, subject to debate, and 36 months is sort of a number that a lot of people seem to agree on, and the overall hazard ratio is about 1.6. I put number location of lesions, because remember, they can have lesions in 1 lung, they can have lesions in 2 lungs, because it's a paired organ, and they can have lesions in the lung and the liver, yeah? But again, less is better. And so is the cutoff 1 versus more than 1? Is it 4, less than 4, or more than 4? Most people put it at 4, and you can see that there is a significant hazard ratio associated with increasing number. Whether it's 1 lesion in each lung or 2 lesions in 1 lung doesn't seem to make much difference. Whether you have 1 liver lesion, 1 lung lesion, or 2 lung lesions doesn't seem to make much difference. So all of that is not a key indicator. Lymph node metastases in the setting of pulmonary metastases for colorectal carcinoma is a very poor prognostic indicator. And if you know you have lymph node metastases, you shouldn't be operating on these patients. And if there's suspicion about the mediastinum, this should be staged. And I won't go into the whole debate about whether you do it endoscopically with EBUS, whether you do it surgically with EBUS. And if you're doing it surgically with EBUS, I would suggest that you choose your thoracic surgeon extraordinarily carefully, because mediastinoscopy, there's one report from the United States where 50% of mediastinoscopies, there was no lymph node tissue in the samples. So you want someone who knows what they're doing with a mediastinoscope, yeah? I'm not at all obsessive compulsive about these things. I don't have strong thoughts. Never mind. Moving on. Pre-thoracotomy CEA levels, again, you find 2 numbers in the literature, 5 and 10 nanogram per milliliter, but you want the pre-thoracotomy CEA levels to be low. Other factors that are much weaker and there's not consensus: size, primary tumor size distribution, age of the patients. And age, we know in surgery, is a very fluent thing, because let's face it, there are 85-year-olds that are extraordinary. I recently had an 88-year-old woman. She had an open lobectomy on Tuesday. She went home on Thursday. 3 weeks later in clinic, she was taking 0 pain medication and life was entirely back to normal. And you've all seen 45-year-olds that are a perfect train crash, yeah? So age is a combination of age and how they're living with it. Is surgery the only treatment option? You've already got a flavor that I'm not going to say that surgery is the only treatment option. There's also stereotactic radiotherapy, also known as SABR, and there are ablation techniques. In the lung, microwave ablation is better than having a senior moment. It'll come back to me. The other type of ablation, RFA. Yes, thank you. In the lung, microwave is better than RFA because you don't have a heat sink effect. If you have a major vessel near to it, the heat won't dissipate through the blood. And we don't really use cryoprobes in the lung. But microwave ablation is a good technique, and clever doctors know how to cox and box or mix and match. So if you have a 4 or 5 millimeter deposit that's in the middle of the right upper lobe, and you have two very peripheral, 2 centimeter peripheral lesions, of course it's better to take out the 2 easy lesions with surgery and then ablate the deep-seated lung lesion in the middle of the right upper lobe than to do a right upper lobectomy and 2 metastasectomies, yeah? So you have to cox and box a little bit clever. In conclusion, pulmonary metastasectomy is reserved for the few patients with few metastases. We've seen ideally less than 4. Ideally, you want a long disease-free interval with a low pre-thoracotomy CEA level, and you certainly don't want intrathoracic mediastinal lymph node involvement. Metastasectomy does seem to offer valid treatment options for these patients and does seem to contribute to the cure of some of these cancer patients. These patients will require multimodality treatment and must be managed through specialized MDTs. And you notice that I put an S on MDTs because there are 2 of them. There's the colorectal MDT and there's the lung MDT. And the 2 need to be working hand in hand like very good friends that get along well together, not like a bunch of squabbling school children. And if these current recommendations are followed, the 5-year survival should be more than 50%. As you've noticed, I don't have any strong thoughts about anything. Thank you for your attention.
Thank you very much, Michael. That seemed to me like a lecture of applied common sense and great logic from someone who's been in the field for many, many years. It's really lovely to hear someone, albeit with strong views, see the world very clearly.
No, I don't have strong views on anything, me. No, that's not me.
Does anyone have any questions? Simon.
Can I just ask 2 questions, just to clarify then? So if anybody's got thoracic lymph nodes, that's an absolute contraindication, is it? You wouldn't touch them?
If they have proven mediastinal or hilar lymph nodes, no, I will not offer them metastasectomy.
And the second thing is...
In colorectal cancer.
Yes, sorry. And the second thing is, have we got any evidence about our microwave or RFA ablation in the lung? Because the colorectal liver mets, I think it's becoming, the literature's getting out there, isn't it? But is there any equivalence or non-inferiority between surgery and ablation in the lung?
The technique that probably has the lowest local recurrence rate remains surgery. But like I said, if you've got a 5 millimeter lesion in the middle of the right upper lobe and it's going to mandate an anatomic lobectomy, I think that patient is better treated with an ablation technique. And again, ablation techniques, like everything, it's a question of selecting the best cases, because that 5 millimeter lesion with an ablation technique, the probability of having complete eradication is extremely high. Because when we talk about a 15% local recurrence rate with stereotactic radiotherapy and with ablation techniques, it's taking into account both the ideal targets, that 5 millimeter lesion, as well as the lesions that are reaching the upper size limit of the technique, which is around 3 centimeters in size. And so the 15% recurrence rate is for all comers. And so it's also a question of choosing the best technique. So if you have a 3 centimeter lesion in the middle of the right upper lobe, I'll do a right upper lobectomy without any hesitation. But for a 5 millimeter lesion that you can easily ablate with a fairly high level of confidence, and don't forget, these patients are going to be followed. So you've ablated it, and 2 years later it's coming back again and there's no disease elsewhere, well then the patient will have their right upper lobectomy. So it's not exactly as if, you've cut them off at the knees by doing an ablation. Have I answered your question?
Any other questions?
Yes.
How is the service set up between, say, DGHs who do colorectal surgery and cardiothoracic?
Very, 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 very well, because I'm a very busy thoracic surgeon. And most of my practice comes from DGHs, because I go to 3 outside MDTs, and that's where my patients mostly come from. And it works extremely well, because we are adults who respect each other, who talk to each other. We do that old-fashioned thing called taking out our phone and talking to each other rather than texting and emailing in difficult cases, yeah? And it's something you guys, there are 2 things you have to learn. You have to learn to talk to each other instead of all this instant gratification of electronic communication. And again, approaching retirement and talking about life-work balance, because that's what we were talking about a few minutes ago. Take your email out of your phone. Separate work from home. You do your work emails at work, you go home, you spend quality time with your family. And stop answering work emails at 9 o'clock at night. Yeah? So
that's the take-home message.
but it works extremely well, because the colorectal MDT and the lung MDT, we both know the rules of the game, and the patients go back and forth seamlessly, and difficult cases we talk to each other. It works extremely well in DGH land, because that's where all my patients come from.
Excellent. Right. Well, it's getting, I think it's been a long afternoon. As much as I enjoyed this morning's round table, which I did enjoy, I thought it was great, I think it's probably a bit late for round tabling now. So with that, we will convene the meeting tomorrow morning, 10:30.